Thank you, everyone who's joining us. This is my very first time doing a Zoom style meeting, and it's very different from anything else I've done, just kind of speaking into the void and not seeing anyone's faces. So forgive me if it gets awkward from time to time. But my name is Chelsea Erickson, and I got to pick this topic myself. And I love this topic because I feel like it's something easy that hopefully by the end, today you feel like I can do some of this on Monday morning, or if you work Friday morning when I get back to work, and it not be as intimidating. So I'm just going to start with a little bit about me here. So this is my family here. I grew up in central North Dakota, right along the Canadian border. So you might hear it in the accent a little bit from time to time. My husband, Sean, is in that photo. We've been dating for, it would be 21 years this year because we started dating in high school and married for 15. And this is his office that I'm working in. This is our house. He works from home for a company based out of Omaha. And we have 3 kids. That's Evie and Mac and Ellis. Evie is 11, Mac is 9, and Ellis is 7. And they all started school yesterday, was their first day back. And so I currently live in Grand Forks, North Dakota, but practice in East Grand Forks, Minnesota. So just drive right over the river every day to practice. I graduated dental school from Creighton University in 2010, and I loved it. Great school, great comprehensive education that I got there, gave me a good heads up, good head start, I should say. I'm in multiple study clubs. So you see the Starfisher, that's one of them. Local and some national ones. I get to go to Baltimore, Memphis, and I'm just kind of a CE junkie. The Pankey Institute is, I started there right out of dental school, probably 6 months out of dental school, went through all the essentials courses, and have done some focus courses, namely the sleep, the women's retreat, the equilibration. And then I've also been to Spear, done some of their airway, most specifically with Rouse. And so I have a lot of continuing education behind me, and then bringing me to Paul and my Acorn group. So this is how muscles and Pankey essentially got started for me. This is my partner in practice, Paul Statham. I job shadowed him in undergrad, and then I started working with him in 2010. That's the practice I've been in. And he encouraged me to get down to Pankey and introduced me to his mentor. Right there in the picture is Herb Blumenthal. And then in that picture is also his wife and another study club member of ours. She's a dental hygienist trained in myofunctional therapy, and they're at my house in this photo. And so if you want to know the most you ever can know about muscles, you gotta meet Herb, or if you can't meet Herb, then you gotta meet my partner, Paul. They are incredible when it comes to this, but today should just be kind of a cursory overview of sorts. And so in this presentation, I have no conflicts of interest. I get to help out at Essentials too when I go down to Pankey, which we're paid a small stipend to cover our airfare, but otherwise I'm not paid to do this stuff. I just love to give back and share what I've been given. So let's move on to what we're going to talk about today. So our learning objectives. I want to talk, like everything, we want to start with why. Why is this something we want to learn about? And I want to do a review of some muscles. These are kind of the muscles I found that I do on pretty much every new patient in my practice. You can learn a lot more, but this is just going to be kind of get you an idea of what might be going on. The Deprogrammer, I personally learned them in dental school, but I didn't learn them well. And I was told to put it in, leave for 10, 15 minutes and come back and see. And I really didn't know what I was coming back to see. And so hopefully demystifying that for some people who are also kind of in that same boat. What was that supposed to do? And then once you've done the Deprogrammer, now what? Now what do we do with this? Where do we go from there? So I'm going to start with why here. So the why here for me is, I think, as this picture shows, it's a huge puzzle piece, a missing puzzle piece that in general dentistry, we skip over. We don't connect this piece. And if we just would, it would bring these other three bubbles that you see here together. So much easier for you and for the patient. It's as much information for you and also making them aware. And so it really helps first in diagnosis. TMD and tooth pain. 90% of TMD cases are occlusal muscle. So not truly in the joint, that's about 10% of the cases, but it's muscle. And so if you don't know how to look at the muscles or feel the muscles, you're going to miss out in a lot of these cases, and you're going to miss out on kind of a reference point of where did they start and where did you get them? I don't know if you've ever had that experience where someone comes in and says, well, this tooth over here that you just did really hurts. And you're like, no, sorry, we worked on the other side. Patients' memories are short, and they sometimes forget, and especially with pain like this, how far they've come. And this is an easy way to remind them. And so then have you ever had this experience? Is this pain coming from a tooth or is it coming from a muscle? They'll tell you, Matt, this tooth hurts right here, my lower left tooth. And you do the tests and you do your palpation and percussion and cold tests, and you just can't figure it out. And then maybe you send them to the endodontist or oral surgeon to figure it out. And sometimes that still happens. But the thing is, there's a lot of referred pain patterns. If you look at this view, this is Janet Travell's work, and muscles can refer. And if you look down at that bottom left-hand corner, look at where the temporalis refers. These trigger points that you can find on the temporalis actually refer to the anterior teeth, the middle portion, the middle, premolars, and the back posterior fibers to the back molars. And so isn't it, wouldn't it be great to know, I can't find a tooth problem, maybe I can feel a muscle and recreate that same problem and say, look, this is TMD. You don't actually need a root canal. And unfortunately, you might have even seen quite a few cases where people get serial root canals because that tooth, it's just, okay, then the endodontist or the dentist thinks maybe it's the tooth next to it, and the tooth next to it gets treated. And it was never the tooth to begin with. And it's really sad to see that happen. And then creating an awareness for both you and the patient. I don't know how many times you've also experienced in your practice, I just want a cleaning, when they come in and you ask, what brings you in today? I just want a cleaning. And we hear that a lot. But sometimes if you sit down, well, every time, if you sit down and you take a look and you ask more questions, you feel these muscles, it creates an awareness for both you and the patient as to what really might be going on here. So in a case like this, patient comes in and says, I just need a cleaning and I need this filling fixed. My dentist keeps filling it and it keeps popping out, and they're just a terrible dentist. And I heard you're great. So can you put that back? And from first glance, that looks like a pretty easy fix, right? I mean, we all know hard to keep there a long time if they're biting and chewing things, but otherwise a fairly easy fix until you look a little closer and then you see this. And if you show them how that tooth keeps on chipping and you say, I can fix it, I can put it back for you. But until we fix this other thing, why you might be doing this pattern, it's not going to stay. And now you've just created ownership for them and to tell them how long they can expect this filling to last. If they don't take care of the original cause, it's just not going to be a good deal. So, sorry. And so a lot of people will say too, I used to grind my teeth, but I don't do that anymore. How do you know? Is this tooth grinding that you see in this photo here, is that still happening? Or did that happen one time or a time when they were 10, 11, 12, and it's not happening anymore? Well, the muscles are going to tell you that. The muscles are what's moving that jaw left and right if the teeth aren't sensitive and aren't telling you. So kind of showing these things, feeling these muscles, it plants the seeds, sometimes guides the patients into asking more questions or hopefully even asking for treatment. How great would it be for patients to ask you to fix this versus you telling them they need it fixed? So this is Erica. She gave me permission to show you all this. And she came into my practice, I believe in June. No chief complaint. She only wanted a cleaning here. And so we're taking notes. And before I check and feel, I often explain to them what I want to find. Let's say we take a general series of photos of all of our new patients, and I go through them. This is different. Everybody has their own flow, but I go through them right after I meet them in my conference room, have a conversation about what brings them here. Then I bring them back to our treatment room and do our set of photos and set of x-rays. And before I even touch them, again, I sit down and I go through photos and x-rays, and hopefully can show us what we might find here, and kind of hint at what we might find here. And so I will explain to them, when we start to look at your bite, as you bite up and down, we want your back teeth to be doing all the work. They're meant to take that work. But if you start to slide left and right, we want to see your front teeth doing all that work. Back teeth shouldn't be involved. When back teeth are involved in left and right, that's when they crack, that's when they break. And if you have too much up and down, they can also crack there too. But the front teeth should be guiding. And so then they can kind of look at these photos and see, gosh, are my canines forward guiding me? What's happening? I don't have to necessarily tell them. I've already set it up what we would like to see. So with Erica saying no chief complaint, I just want a cleaning. So here are our photos. And I just want to have you take a second and kind of look and see what you see here. And I know this isn't super interactive. I'd love to hear what you see. But I get to put this up for her too and ask her, what do you see here? And of course she says, well, that's not very even. It's like, yeah, look at that. That smile line kind of goes higher on the right. That right central is a lot shorter than the left central. And if you look at the lower incisors too, you have a taller central incisor and some shorter central incisors, and maybe somewhere there. Of course, she doesn't use incisors, but my front teeth, look at their different lengths. And then looking from this occlusal view, what do you see here besides maybe a little bit of lunch in the upper left there? What I see is quite a few composites and some wear from the occlusal view. And I see one crown up there on that right side. And I get a little bit interested in that. Why is that one crown there? And I'll even ask, why is that? Was that crown done? Sometimes they remember and sometimes they don't. The lower view, what do we see here? See tori, see that she has had ortho, maybe some leaking fillings, especially. Yeah, I can see a couple composites that aren't maybe going so well. And then our side view, this is looking pretty good. The teeth are pretty much fitting into each other. That's what I show them. And then as they slide, man, remember how we said we wanted the canines and the front teeth touching? They can't. It's the back teeth are touching. It looks like almost all the way to that back tooth, even to that crown tooth in the very back. It looks like it's touching when you're sliding. And other side, look, it looks a little bit different, doesn't it? Tucked in, what do you see? And when you slide, well, it looks a little bit better. Maybe that back tooth isn't touching. We're getting over to those front teeth. So we'll see what that means here. So we've written this all down, and I just want you to kind of pay attention here to what we're seeing. We're seeing her right lateral excursives. Yes, that whole working side. Her left lateral excursives, her whole right side. And nothing's touching on the left that she perceives. Her protrusive, same thing. It's that whole right side. So it gets me thinking, what's going on here? Again, I just want a cleaning, but we know that this is not an ideal and it's not a protected bite. But how do I explain to her that we need to do? How do I know I even need to do something about this? And if we do, how do I explain to her that we do? And so we'll move on here to some muscles. So is it currently happening? Is it something in the past? And this is how I explain it to patients. If it's currently happening, it's like going to the gym every night or during the daytime, whenever you're doing it and you're lifting weights. These muscles are going to get bigger. They might get tighter if you've had a really hard workout session. They might be just really sore, or you might feel tension bands. I don't know, but the muscles will tell us that they've been working out a lot lately. And then before you do a muscle palpation, you want to establish a language. And so this is all subjective. They kind of get deer in the headlight kind of situation. they feel like they might not get it right, or they could get it wrong, and just let them know this is just how you're feeling today. It kind of gives us a baseline. And you establish a language of, okay, so, and I usually pick up a point on their arm and say, does this cause any pain or discomfort? Often they say no. And okay, this is a 0. I use a scale of 1 to 10. 1 is going to be like tension, tightness. It doesn't hurt, but you can feel the band, the muscles tighter, all the way up to 10 being the worst pain ever. This is the way I do it. I've heard scales of 1, 2, 3, of plus minus, like yes, it hurts, or no, it doesn't, just yes and no. I don't really care. Just develop your own system of communicating with the patient so they can tell you, compared to this, how do these other muscles feel? I can tell you that some people say 10, 10, 10. You know it's not a 10, they're not crying. And other patients do this with their face, and you're touching them, they say that's a 2. It's like, what's a 10 then for you? So it's very subjective, and and the more you feel muscles, the more you will know just by feeling what they should be saying. Like, this is a lot bigger than it should be. And if they're not accepting, there might not be tension, especially with men. They don't hurt things. They just break. They never come in and say, this hurts. Not very often. The women say, it hurts. I have headaches. I have pain. Men just break everything and say, but it never hurt. And so everybody's different. And then the other thing that I want you to know about muscle palpation is that I don't really care if you know you're right on the digastric or the masseter or the temporalis. I don't care if you call them masseter or temporalis. Call it point A, call it point B. Just go there one time, get your numbers, get your readings, do a deprogrammer, go back to that same point. It doesn't matter if you're exactly on the muscle here. So we're going to start with just kind of going over some easy muscles. I feel they're easy to do in your everyday quick check here. So first of all, the digastric. And I'm just kind of flowing through these muscles, how I flow through them on a patient. And I'm going to show you a video of that here too. So digastric muscles depresses the mandible, and it moves the jaw left and right, or if they both, it's kind of like reins on a horse. If they both contract at the same time, they'll be moving that jaw back. And this you can often find sensitive in someone who has like anterior fremitus. If they're hitting their first point of contact, like post-ortho, something like that, is a front tooth, to get their teeth together, they'll have to move their jaw back. And you'll often find this muscle tender. And so that's why I included it. Is you see an anterior first point of contact, check this muscle out and see how they feel about it. But this, goes through near the highway through that strap there. So there's an anterior portion and a posterior. I can tell you in my experience, in my quick and dirty one, I don't very often do the anterior portion. I do mostly the posterior, just to get an idea if I need to do further exam. But the posterior is right at that angle of the mandible. Here, that's the anterior. Here's a little more posterior, I think, where this fingers are showing you the palpation. I go a little bit further forward than that, and you'll see it in the video. But again, if I'm not exactly on the digastric and I'm a little on a pterygoid, I don't much care. I just want to know how that feels to them. Next muscle is the masseter. It's our major closing muscle. So this should be pretty easy for most of us dentists to find. You just can have them clench, and you can kind of feel the anterior and posterior border of this muscle as they clench. And this muscle is very tight and has a lot of trigger points. And so palpating it might take you you might need to press a little bit longer to get a response. Once you can, and it'd be great for you to kind of feel this on yourself right now. Find it, clench a couple times, and see how it feels. And if you can find a tight spot, hold it. And you can see, that picks up in pain a little bit as I hold it. So just doing a quick touch isn't going to work so well on this muscle. Just kind of feel around yourself, find a knot, hold it for a little bit, and then ask them, what do you feel here? Moving on to the temporalis. Also a major closer, very big muscle. Another one dentists can find quite easily. Again, have them clench a couple times and you'll feel it's thinner, but you can feel this muscle pop out. So often our clenchers are going to be very sore on the temporalis and the masseters here. And it's just it has 3 sets of fibers. And so it's a pretty big muscle to cover. Just kind of walk your way along this muscle. It doesn't show me walking here. Walk your way along this muscle. And again, same thing. It might be hard. You might have to find a knot and then press on it. to get a response because of how tight these muscles can be. Next muscle, the trapezius. The traps is a huge trigger point. If you've ever taken like injection courses for Botox, I have AAFE up here. That's going to be one of the major ones they show you. It's going to be masseters, temporalis, traps. And you can feel it for yourself too. Just go in and grab the top of your trap, and you can find, a lot of us dentists, you can find that trigger point. It's going to be right about there at that height of that trap. I'm going to use just one point there. I'm not going to grab the whole muscle. I'm just going to put my finger, my thumb on that common spot. And you'll see again in the video what I mean by that. It's a little blocked by her bib, but hopefully you can kind of get an idea. But I mean, just feel these on yourself and you'll kind of know where to go on patients. SCM, this muscle is also very often tender. It's used in turning your head and tilting your head. Also very much a trigger point somewhere along this muscle. It's a very long muscle going from behind the ear all the way down to the neck. So you really have to take your time and walk your way along that muscle. You can see how in this picture, grabbing it on either side here, all the way down to the sternal or the sternal branch here. There's also a clavicular branch, but it doesn't matter. But you'll often find something here in this muscle as well. Medial pterygoid. So now these two pterygoids are a little bit harder because they're just not as big extraorally like our temporalis is or our masseters are. These you will find externally, right here, more at the angle of the mandible and pulling out. You remember that's about where we found our digastric too. Our digastric is going to be more in. Medial pterygoid is going to be more taking your fingers and pulling out right at that angle. That's the extraoral attachment. I actually pretty much do the intraoral attachment. So you can see it here where it might run inside the mouth. Your pterygomandibular raphe, right? We know where that is. That little dot's where we inject. Just go past, towards the throat side, past that injection site, and you're going to be on the medial pterygoid. It's often very sensitive, so be careful. And people, warn them that you're going to be touching a little bit further back there because your gaggers, or it might go, but it's a quick touch. It doesn't have to be long. And that's often a very, very sensitive muscle. And that's where I prefer to palpate it. Again, are you only touching the medial pterygoid? I don't know, maybe not. But if it's tender, do your deprogrammer, go back there and see if it's tender. Next and last muscle is the lateral pterygoid. So this muscle acts like, it has two bellies and it really acts like two different muscles, but this muscle is interesting because it's the only one that inserts into the disc. So if you have them open and you put your fingers into that joint space, if they say it's tender, what's tender there? Are you palpating a swollen disc or retrodiscal tissue, or are you palpating the lateral pterygoid? It might be hard to know, but they say they have pain in their ear. It might be that this lateral pterygoid is really tight. And so palpating it is a little bit difficult and somewhat controversial. I hear people asking, can you really touch it? So where you're going to go intraorally is the hamular notch, right? Where the third molars will be right up there. Again, be careful. It's often a very, very tender spot. And are you touching the lateral pterygoid? I don't know, but it's tender. Do the deprogrammer, go back there and see how you feel. And so that's how you can see it's going into part of that disc. And so I'm going to play a video here. This is Erica again, and we're doing the muscle palpation. So in this video, she agreed to come back after my new patient, and I saw all that right side stuff going on. I didn't want to do the muscle palpation because I didn't want to give anything away, but I knew I wanted to record it for this presentation. So this is her first time feeling this. So first we're going to do the digastric muscles, posterior, any tenderness either side right here.
A little bit on the right.
Right side, what number would you give that?
5.
5. Anything on the left at all?
No.
Okay. Masseters, right and left side. Any tenderness here at all?
The right?
Right number, what number?
6.
That's 6 there. Anything on the left at all?
No.
Okay. Temporalis. Anything there at all?
Probably like a 3 on the right.
Okay. Traps. This is where you said you carry some tension, but any tenderness here today?
On the right.
Right. What number would you give that?
5.
5. All right. I'm going to have you turn your head to the right for me. I'm going to walk down your SCM. Any tenderness there at all?
A little bit, like a 3.
3. Okay. Other side. Walk down the SCM. Oop. I'm sorry.
That's
what
okay.
number would you give that?
7.
7. Okay. I'll have you go straight forward into oral 2 muscles. Medial pterygoid right there.
6.
6. Right there.
That was probably a 7.
Okay. Any tenderness right here?
4.
Okay. And how about back here?
Nothing.
Nothing. Okay. We're going to set up and check your range of motion of your neck. So I don't care, again, which direction you go first. I want to have you turn your head and not your shoulders so you feel tension. Okay, where do you feel the tension there? Right here? Right there. That's the upper trap. Okay, and let's go the other direction.
That's way over here.
Okay. Do you feel like you go one direction more than the other? Another? Yes, that one's much easier.
Okay, so a couple of things to note there. I do bilateral palpation at the same time. And as some people say, I only do the right and I only do the left. So you can be more clear. Again, it's preference. Except for you notice with the SCM, I have them turn their head into my hand so I can see the SCM pop out. And then I also have them sit up and do this head turning thing. And I instruct them. I don't want them to turn their shoulders. I just want them to turn their head. I want them to go nice and slow, and I want them to stop when they feel tension. So even a hesitation, that's enough tension, and I want them to show me where that is. And I do that head turning thing right after, at the very end, because next I'm going to be doing a deprogrammer. So I'll be showing that to you in a second. I see some questions popping up here in the chat. I think the answers are going to come to that a little bit later here. And if I don't, I'll come back to that, but I'm getting to some of that here. So first, okay, so deprogrammers. First of all, does occlusion matter? And I think that is a tricky question. A better question would be, should occlusion matter? In my opinion, occlusion shouldn't matter. We don't bring our teeth together in a normal functioning system other than swallowing. We don't bring them together when speaking. We don't bring them together when chewing. And currently our diet is soft enough that wear shouldn't happen due to our diet. Wear is common, but not normal. And that's the thing I talk a lot about with patients. What's something that's very common? Snoring, cavities, but is it normal? No, we need to do something about it. So, but does occlusion matter? Yes, because we have people who clench and grind, and they know when someone knows their teeth so well that you have to do that little perfect. That person is over referencing their teeth way too much. They're bringing them together and they shouldn't be doing that. And why are they doing that? Well, there's a whole lot of reasons behind all that, probably a topic for a different day, but clenching, grinding, daytime, nighttime. We'll go into a little bit about that later, but it's a deeper subject. And then what exactly do deprogrammers do? Well, the thing I was taught in dental school, like I said, put a deprogrammer in, walk away for 10 minutes and come back. Actually, no, they should be working instantly. And what they're doing is, we talked about occlusal muscle, right? Occlusion. We're taking the occlusion out of the picture. We're putting the pressure on just a couple of teeth, and we're tapping around and letting their brain realize that the teeth aren't there anymore as far as the brain's concerned. If there's any reflexing about that bite, if you were walking with the tack in your shoe, there's no way your body will continue to let you walk normally. You're going to have to reflex. around that. It's not voluntary. Your brain won't let you hurt yourself. And so sometimes if your bite is hurting your muscles or could be hurting your teeth, your brain might be bracing and turning on muscles that shouldn't be turned on. And so this deprogrammer lets that occlusion, that bite, just kind of disappear. And then we get to see what happens to the muscles. And then different types of deprogrammers. There's quite a few: the Lucia jig, leaf gauge, acrylic. You can make your own homemade acrylic one. That can work beautifully, especially if you have a lower incisal edge that's all uneven and you can't get a nice solid point. Called the Pankey Deprogrammer, which is essentially a Lucia jig. That's what's here. And this is what we're going to be doing. So next video is a little bit longer. It's me putting this deprogrammer in and seeing what happens, what her response is. Again, she's never had this done before. What I want you to notice is, if you don't remember how far she could turn her head left and right just before this, check it, watch again, and watch when she turns to her left. Watch, it's kind of hard to see, but watch what her left eyebrow does when she goes to her left. Check this out here.
I'm gonna go over your front two teeth, and I want you to close just lightly together on that. I don't perfect just like that. I want it parallel with the lower plane of occlusion. I don't want it at an angle. So go ahead and open for me. And I'm just gonna reline it with a little bit of material here and place that in. Very good. And lightly close together there and stop just there. And I'm just going to have you hold there for a few seconds. Okay. Now I want you to tap, tap, nice and solid. And now go to your left and to your right and just keep tapping. Lower jaw, move, yes, as much as you can tap. Go forward and backwards. Very good. Can you relax your jaw one time? And I'm just gonna see if I can get you to, yeah, so as much tapping as you can do. I'm gonna set you up and we'll just check to see if we've had any change here. Go right and left too. Nice.
Turn my head.
Just tapping for now. Lower jaw as far as you can to the right and to the left. Good. Perfect. Now we can just relax. And now I want you to turn your head and see if there's any change here. Okay. So that was the way we could go pretty well first. You notice any difference there? Okay. How about the other direction? Further. Where's the tenderness now? Same spot, or did it move?
It's still a little bit lower.
Okay. So do you feel like you can move further that one direction, or it's less tension that one direction?
Easier to the left.
Easier there. Okay. And we're just going to recheck some of these muscles here. Oh, right here. It's been fixed. Sorry about that. Okay, most of our discomfort was on the right side, but I just want to see if any of this has improved. So any tenderness either side right here.
Well, a little bit on the right, but probably only like a 3.
3. And anything on the left? Okay. Masseters. What number do you give that there?
Probably a 2. Hardly can tell.
Okay. Temporalis. Good. Traps either side here.
Just a little bit on the right.
What number would you give that?
Like a 1 or a 2.
Okay. I'm going to have you turn your head to the right for me. Any tenderness along that muscle there?
Just a little bit.
What number would you give that?
3.
3. Let's go the other way. What number would you give that there?
That's way better. 2 or a 3.
2 or a 3. Okay. Intraoral. Go ahead and open for me. There.
3. Not much there.
Not much. Okay. and lateral.
Yeah.
Okay. Medial. Lateral. Good. Okay, so overall, do you feel any change in how these muscles feel with this?
That's bizarre.
Bizarre.
That when I go the other direction, there isn't as much tension.
Yeah. Do you register the difference? Like even just relaxing now,
Yes.
can you feel?
Yes, very much so.
Okay. Cool. Thank you.
Okay, so listening to myself, just keep tapping. I feel like, oh, sure, you betcha. You can hear my northern accent there, and I apologize for that chair. It has been fixed. But I just want you, see how fast that worked. It didn't take long. We just had her tap a few times and it worked. And so here's her new findings, initial and after, especially like that SEM. She said 2-3, so I made it higher, made it a 3, but we had a lot of muscles shut down. So that tells me, okay, we got an occlusal part to this. Also, I asked her to write down then I gave her the symptom sheet afterwards. Can I think of all things that might be related to this? So now someone who came in with, I just want a cleaning, this is all her symptoms. And if you look at the bottom, pain in shoulders and neck caused by clenching and affecting correct bite, having migraines, tori is getting bigger on the bottom jaw. Well, that sounds like to me, she's become self-aware. We just did a code diagnosis. I didn't tell her that. She came to that because of, that's bizarre. Look how much better I feel. Maybe my bite does have something to do with it. So now when I talk about splint therapy or whatever we're going to do next, it's a whole different conversation because she's accepted where she is and the fact that her bite might have something to do with it. And so, what do we do from here? So what kind of results did you get? Not every patient's going to shut down like that. In fact, I tell them, I don't know if this is going to make you better, worse, stay the same. All of those have some type of meaning. If I make them better, I'm thinking, okay, there's definitely a occlusal muscle standpoint to this or part of this. And so I can help that. If it's worse, I'm thinking maybe I either had that deprogrammer in there at the wrong angle and I'm distalizing that joint, or I'm putting more load on that joint and it's actually a true intercapsular joint issue. And it could be both. Some muscles got better, but I also made this worse. So then that's where it could be a joint issue plus occlusal muscle. But yeah, if I make them worse or if it stays the same, I think we need something else here. Maybe we need to bring in some more imaging and look closer at the joint itself. Maybe we need a referral to neurology, just depending on what we're finding there. And so what results did you get? If you got the positive, I think this is occlusal muscle and what can I do? So first I think we need to bring sleep around. Sleep is, every dentist knows now, it's just kind of in our face and we have to start paying attention to it. In fact, the ADA says we need to screen for it. Doesn't mean you need to treat it. It doesn't need to be part of your practice. It just needs to be part of comprehensive care and figuring these people out. So screen for it might be just, the simple Epworth sleep questionnaire. You can even go as far as, getting your own pulse ox. They're cheap. The Christine LaJoy at Great Lakes, she works with Dr. Steve Carsonson, who teaches the Pankey and the Spear sleep course. The Pankey sleep course is amazing, by the way. It's so great. Dr. Else from Spear also works with Christine, and she'll get you set up. And again, send them home, test them. If you get the test and you don't want to do anything about it, then you can always you can always refer if you don't want to do anything about the sleep, but you should be very aware of if you put a splint in, you can definitely impact their airway for better or for worse. If you've ever done this and you had a patient say, I can't sleep with that thing in my mouth, I just can't sleep. Is it because you didn't adjust it beautifully and they just need space? Or is it because you're negatively affecting their airway and you're making their sleep worse, or vice versa? If they say, I love this is the best thing, maybe you are amazing, but also it's supporting their airway, supporting their sleep. It can do both things. So potential therapies here, bite splint therapy is usually high on my list. It's got to be nice, well adjusted, building that ideal bite in. It's essentially ortho or equilibration in a piece of plastic. That's sort of how I frame it for patients. This little piece of plastic is giving you your ideal protected bite. You won't necessarily stop clenching. You might not stop grinding, but it is going to protect your teeth from those things. And hopefully, with what we saw with this deprogrammer, hopefully support some of these muscles shutting down, less pain. I can't guarantee them it's going to take care of everything, but it was positive when we see these muscles shut down. But it's just one part bite split therapy. Sometimes you might need to bring in Botox if you have a huge clencher and you just want to shut down those muscles in the beginning. It's not a full treatment. It's treating a symptom, but it can help get you started off in the right direction. Equilibration, making sure their bite is harmonious. If you know you can easily take it to models and you know you can get that, what we saw earlier, she had the crown on that right side that was bumping. Can I just easily adjust that crown out of occlusion, and could it make a difference? That's a potential. Ortho, or the teeth in the right space. If we know it's related to bite, let's change the bite. Body working. Dr. Steve and I work with physical therapists all the time because I'll show you here in a minute why. But these people are, it's often very complicated. When you saw that whole checklist, it's not just the bite. It's just, this is one of the symptoms and we can help, but to be comprehensive, we need to be looking at the whole picture. And so this is what I mean here. We affect with our dentistry, the entire system. And so what I'm going to show you here is a video. I would have loved to do it with Erica. I just didn't think about it. In one of my study clubs, we work with a physical therapist, and he's shown us this. If you put a deprogrammer in, we saw how that neck turned much better. It doesn't stop at the neck. So this is actually my assistant, and what she's going to be putting in her mouth is her splint that my partner, Dr. Statham, actually made for her. But watch what happens. Okay, we're just going to see how the hand can't get all the way to the chair. Like we talk over this thing. Both sides pretty locked up. Now go ahead and put your splint in. Tap, tap. Try that again. And now she goes all the way down here. Increase the range of motion there. All right. Okay. So did you guys pick up on that? How crazy is that? We put the splint in, and before she's locked up and she doesn't have full range of motion, put the splint in, and all of a sudden she gains range of motion in her shoulders. If we did it with her hips, we would see the same thing. And that's my postural restorative physical therapists have shown me so many crazy things. And so it's not just a splint though. That's something to keep in mind. It's the dentistry that you do every day can impact people positively, but also negatively. And so we need to be aware of that and need to be aware of how we're treating our patients if we're being comprehensive and helping them figure this out. And so that's what I have for you today.